Hi, Melissa.
Melissa, how are you?
Good. How are you? Welcome.
Thank you. So happy to be here.
I'm going to do let me do an introduction. Are you ready to go?
I'm ready to go. If folks are ready, I'm ready. I know we said 2 o'clock, so I don't know if our colleagues are still grabbing lunch or something, but whatever works for you, I'm flexible.
Let me just welcome everybody back. I think we have new people, so I'll just do a little overview of the kind of how things are going this afternoon. So, welcome everybody. I'm Catherine Carmichael. I'm the Executive Director at Nutley Family Service Bureau. Welcome to our Inclusive Mental Health Symposium. This is the first of hopefully many annual events in the future. And it's been a really rewarding day so far. We've had lots of we've had a very educational and motivational day with our presenters so far today. And now we have Melissa Cheplic, and Melissa has done workshops for NFSB. And so I can speak from experience that we've had a really impactful time with Melissa. And lots of discussions after she left our organization, and our work has strengthened due to things we've learned from Melissa. So I'd like to introduce Melissa. To say a little bit about her. She develops and delivers training and technical assistance to community providers, state agencies, health professionals, and university students. She's at the Boggs Center on Disability and Human Development at Rutgers. She holds a master's degree from Rutgers School of Public Health and is a NADD certified clinician in dual diagnosis. Melissa develops nationally recognized curricula and presents at various conferences on behavioral and mental health, health promotion, crisis prevention, emergency preparedness, and workforce development. She co-authored the training manual, Mental Health Approaches to Intellectual and Developmental Disability. And Melissa is earning a Doctor of Public Health at Rutgers. So Melissa is going to be presenting a workshop today on mental health and dual diagnosis. And I'm ready to turn it over to Melissa. Are you good
Yeah,
to
I'm absolutely
start
ready.
going?
I'll spend a couple minutes
Yeah,
just overviewing the session. That way, if folks were planning to join it too, they're not missing too much of what we
sure.
intend to share. But I will go ahead and share my slides, and thank you so much to Isaac for the support. Thank you again to Catherine and for Shelley for having me. I'm so grateful for an opportunity to speak on this important topic. And I was so grateful for the opportunity as well to hear from our other colleagues this morning. So it's just been a wonderful day, such a successful symposium so far. So thank you for all you do for the community, and thank you for this opportunity to elevate the work of the Boggs Center. And we'll talk a little bit more as we go through our conversation. So I wanted to speak today about mental health and disability, particularly through the lens of intellectual and developmental disability. So in service to that, I do want to spend a little bit of time talking about terminology, thinking about the language that we use, and some of the risk factors that we tend to identify with people who have disability experiences and co-occurring mental health conditions. I also want to talk practically about the application of the work that we do, and some of the barriers that may exist across some of our systems and some of our service provisions. So we'll have an opportunity to look at some of those barriers. And then since we have such a diverse group of professionals and providers and family members through the community, I always welcome these opportunities to share resources, right? People are always asking for tools. What do I do when we leave here. Give us something that we can take and use and have at our fingertips to make a difference and to make these changes as soon as we can. So I also incorporated an opportunity for us to make sure that we are spending some time looking at those additional tools and looking at those additional opportunities to really elevate what we do beyond our training opportunities. So thank you for that. So let's visit in with a couple of statistics and then think about what that context means for the work that we do. Our colleagues at the National Alliance for Mental Illness tell us that 1 in 4 Americans have experiences of mental health services, diagnosable mental health disorders, that we see that there are barriers to behavioral health and less access to receive mental health services for minority populations. And of course, we know when we speak of minority populations, we're also talking about people who experience disabilities as well. Our CDC data tells us from our behavioral risk factor survey data that the experience of disabilities, adults with disabilities, is that people experience mental distress 5 times as often as their counterparts without disabilities. So 5 times as often. And we're also likely to think that that's underreported, because if you're familiar with CDC and our behavior risk factor survey data, we know that participation in that survey relies on self-report. So the likelihood that we're underestimating the experiences of people who can't take a phone survey, who aren't able to participate, who don't use language to express themselves, who aren't self-report, are probably not included in that already impressive 5 times as many people who experience secondary mental distress. So when we talk about dual diagnosis in the context of disability services, we tend to be focusing on those who have experience of intellectual and developmental disability. So it's helpful for us to provide context to that, thinking about what we mean when we say intellectual and developmental disability. So intellectual disability is a condition characterized by limitation in functioning, originates developmentally before the age of 22, and that people who have IDD experiences also have challenges with the conceptual, social, and practical domain of learning across the lifespan. But I think what's key to recognize and to remember is that quality of life improves with appropriate supports, with person-centered, coordinated supports to help people across the lifespan to have a better life and to access those other services that will elevate them and help them get their needs met. So very early data in the late 70s and early 80s show us that 2 to 4 times people who have IDD are likely to have a mental health diagnosis as well. So a typical population, 2 to 4 times people who have IDD will have that secondary mental health condition. When we look at our national core indicator data, which is health service data from people who self-report receiving services from their service system, the 2012 national core NCI data tell us about 33% of people self-report a secondary mental health condition. And then when we look at that more recent national core indicator data, we recognize that 55% of people self-report having an additional mental health diagnosis along with an IDD diagnosis. So that NCI, that national indicator data, about 55%, it's also consistent with research and data from NADD, National Association for Dual Diagnosis. So when we take all these things together, our NAMI data, our CDC BRIFIS data, information from our National Core Indicator Health Survey, and also looking at our NAD data, people who have the experience of disability, particularly intellectual and developmental disability, are twice as likely to have a secondary mental health diagnosis over the course of their lifetime. So beyond the statistics and the prevalence of this, we want to look more broadly at why. Like, why are people who have IDD experiences more likely to experience a secondary mental health condition? And we've heard about some of them today as we've been through our session, right? Racism, segregation, isolation, unmet mental health and medical needs, having challenges with accessing services and finding providers who are willing to work and support with people who have disability experiences or who aren't able to articulate or communicate. These are challenges that we see that make it harder for people to have the kind of life they want to have, that make it harder for people to get their needs met. And so we see these reasons why people have those secondary mental health conditions across the lifetime, right? There are biological reasons, medical reasons. We know that there's social and psychological reasons. People with IDD are more likely to be victims of abuse and neglect. They're more likely to experience sexual violence. They're more likely to be stigmatized and have restrictions and segregation and lack of access to programs. We see higher rates of bullying across the lifespan for people with IDD. We also see grief and loss, which is a tremendous challenge across the IDD experience, right? We tend to think about grief as it relates to bereavement, but we know that for people who have disability experiences, this transition, this grief and loss is constant, right? Family changes, caregivers change, staff turnover, medications change, classrooms change, the bus route changes, doctors change, and along with all the other lifespan changes that we go through, these are opportunities for people to become disrupted and dysregulated with their life and their services. There's also tremendous grief and loss that comes from these changes. And while we know that these are experiences that are common to all of us, these are particularly challenging for people who have IDD because of the risk factors that they experience across their lifetime. And I know that we know all from our own work and the work that we do, that we see that there's this likelihood for this secondary mental health challenge to emerge over time. So when we use the term dual diagnosis in our circles, pun intended, right? When we talk about our circles, we're talking about disability service systems. When we talk about dual diagnosis, we're speaking about the existence of a psychiatric diagnosis or a mental health condition, along with a diagnosis of intellectual or developmental disability. It's the coexistence of disabilities on two domains. So when we talk about the dual in dual diagnosis, we're really talking about the two domains of disability that exist for people who have mental health experiences that accompany those disability experiences as well. And so we often hear this terminology, this phrase identified as a dual diagnosis, but we know, of course, that people have more than one diagnoses, more than two diagnoses. People may have autism spectrum and anxiety experiences and also a trauma history and have physical needs related to GI distress or asthma, respiratory needs, allergies, migraines. So by no means is the dual in the two intended to talk only about two diagnoses, but really to look at these different domains where we see that disability may emerge. And to think about this more inclusively, we do see terminology IDD-MI or IDD-MH, which really encompasses the mental health needs of people who have disability experiences, even in the absence of that formal secondary diagnosis that we see. Because we know and we'll talk in just a moment about some of these challenges that it's hard to get an accurate mental health diagnosis for people who have disability experiences. So to think more inclusively about mental health needs and to think more inclusively about holistic mental wellness in addition to IDD, sometimes we see this dual diagnosis, IDD, and again, more inclusively as IDD-MH. So across the lifespan, there's different things that precipitate a mental health crisis that can lead people to seek treatment for mental health symptoms or diagnosis. We know that there are medical issues and complications. Deputy Commissioner McGuire mentioned to us this morning that 40% of people who experience disabilities also have unmet health needs that are often recognized when people are seeking treatment for inpatient psychiatric or outpatient psychiatric support. Changes in the environment, any interpersonal stressors, right? Staff and roommates and coworkers, and navigating the neighborhood and not having access to transportation, illness and pain. And of course, we know that people who have disability experiences are also more likely to have trauma experiences across the lifespan, which is absolutely a factor that can precipitate a mental health crisis. So there's different reasons why mental health needs become apparent, right? There's different reasons across the lifespan why we know that people are likely to have those secondary mental health conditions. But the biggest indicator to us that people's needs have changed is when we see behavior change, right? We can see behavior change, and we recognize and we know that people's needs have changed because their behavior has changed. So when we see behavior change, that's telling us that people have needs that are unmet. We also know that sometimes it's very hard to navigate what that behavior change is really indicating to us, right? Behavior change may be a symptom of a psychiatric disorder or a mental health need. People may have other unmet needs that they're communicating to us through their behavior and behavior change. People may have medical conditions and they're feeling pain or discomfort or other symptoms related to their health that manifest as behavior changes. We also know that changes in the environment, right? We talk about the environment as it relates to setting, light and sound and noise and temperature and textures, but the environment is also everybody else who's in it, and meeting other people's expectations and being able to have supports and resources to be successful, and whether or not there's help available, and how to get it, and is there access. So when we talk about the environment, we talk about the setting for sure, but we also talk more inclusively about those big macro pieces about what it means to get our needs met across settings, which again, we know is harder for people who have disability experiences. And then trauma and grief, which absolutely manifest as behavior changes, particularly for people who may not use language to communicate in a traditional way. So from a provider perspective, and I know that many of us in the session today are providers in the community in different capacities. From a community provider perspective, this becomes a challenge for us to understand where behavior is coming from, what the behavior change might indicate, and quite frankly, knowing that this is not a list of mutually exclusive reasons why people may have behavior change, and that we see this overlap of need. So it's helpful from an assessment perspective to not just think about diagnosis, but to really think about needs and how we can start to understand those needs, and meet those needs through the information we have, going about getting the information that we don't have. So I'll share with you some of the training opportunities through the Bog Center. And again, thank you to Deputy Commissioner McGuire for elevating the direct support professional workforce initiatives that have really been working to address the capacity of our direct care staff, supporting people who have IDD and mental health needs. But the way that we do this is through exercises and activities and conversations such as the one that we're looking at now. So Christina manages her chronic migraines with Topamax. She's been missing her tennis lessons on Saturday. She says she feels tired, she has no energy, she lost weight despite exercising less, and her team notices these changes. They set up a consult to explore a possible depression. So again, this is how we tend to become aware that people's needs have changed, right? Their service needs change, their support needs change, their schedule changes, maybe they're reporting some symptoms or some side effects of medication. So in this context, it's important to, again, think about the information we have and also think about the information that we may need. So we have some questions. I want to know how long Christina's been taking the Topamax. I want to know if she's taking other medications. Are there things going on at tennis that we want to find out from her about whether or not she wants to be in that setting with people? Are there other reasons that she may have lost weight? When we look at things like losing weight without exercising, feeling tired and lethargic, changes in mood or affect, it's kind of depression 101 where people aren't showing up and doing the things we know that they like to do. So we see those indicators here, but we also want to think about how we can get more of this information as we start to think about how this relates specifically to Christina and for her experiences. And so there could be barriers to assessment around language. There can be barriers to assessment because maybe different people work with Christina over different settings, and they're not reporting or seeing the same information when she's home or when she's at work or when she's at school or when she's at tennis. So that interferes with getting the information that we need. There can be other things that are causing her symptoms in addition to any organic changes that she might be having, but also thinking about medication side effects, of course. Has she experienced any recent grief or loss? Have there been trauma experiences? Does Christina feel safe when she's at tennis? Are there other things that she has been missing as well? So we know that for a comprehensive assessment that is going to get people the things that they need, we have to have these conversations. We have to know how to ask these questions, and we have to think about, again, the information that we don't have. But I appreciate this example of Christina, and I'm sure we all have similar examples of people that we support with disabilities across the lifespan, where we have to use the information that we have to make a determination about what people need. And it has been and remains consistently difficult to get an accurate mental health diagnosis for people who have experiences of intellectual and developmental disability. One of those biggest reasons, of course, is communication and language needs, right? Most of the assessment tools that we use to identify and diagnose mental health conditions, including the DSM, rely on self-report, right? We're looking at symptoms that people can confirm, that people can report. And we know that for some people who have IDD, who don't use language, they're not able to report or confirm that. We also have the challenge of diagnostic overshadowing. Diagnostic overshadowing is a term that we use to refer to this idea that when we know about a diagnosis, when there's a known diagnosis, such as a disability diagnosis, we attribute all the other symptoms and behavior changes to that known diagnosis. And we typically see this often in the emergency room, or we see this in psychiatric settings where people may present with escalated behavior, baseline exaggeration, having high levels of dangerous behavior. And people have kidney stones, and people have UTIs, and people have bowel obstructions and migraine headaches that look like psychosis in people who aren't able to articulate that. And think about having a bowel obstruction on day 4 without having language, right? It looks like aggression. It looks like self-injury. So we see this diagnostic overshadowing that exists when we're having conversations like we did about Christina, but then also when we encounter supports and services with other health professionals. Medications and side effects. A lot of medications, including neurological medications and psychotropic medications, they can mask and mimic the very things we're looking for to diagnose a mental health disorder. Changes in sleep, changes in eat, changes in energy and appetite and affect and mood. These are the signs to us that mental health needs have changed. These are things that medication can also affect as well. People have multiple diagnoses. We have the challenge of differential diagnosis between different disabilities and between disability and mental health needs. And division of services, right? We know that oftentimes people get their mental health needs met in one system, and perhaps their disability needs met in another system. And this lack of coordination of care across services that may be fragmented can also interfere with people getting their needs met. And then provider access and knowledge, right? We heard this morning that something that I know that we are all very familiar with is that people don't necessarily know where to find providers, like behavioral health providers, mental health providers, general practitioners who have the ability, the willingness, the capacity, the knowledge to support people who have disability experiences or who have communication and language needs that may be different. So we talk about access in the sense of finding insurance and providers that are going to allow for people to get service. And then we talk about access in terms of, finding people, finding providers who are going to meet those needs, even after we've done the work to identify what those needs are. So I think what's helpful sometimes as we're sort of navigating behavior, what are we looking at? Are we looking at an acute change? Are we looking at an environmental change? Are we thinking about the potential for a mental health condition? I think having these guidelines is a very helpful way, like understanding behavior and behavior change is a really important part of this process. And we want to recognize and honor behavior change as potentially an underlying mental health condition, because we want to prevent psychiatric disorders from being misidentified or being overlooked entirely because of diagnostic overshadowing or because of behavioral overshadowing. So we see some of these examples here. The rapid onset or increase of a change in behavior or symptoms is very highly correlated with mental health needs and behavioral health needs. We think about medical or health symptoms that are unrelated to an injury, they'll be more insidious, right? We think about ulcers or arthritis. They don't happen overnight. And I think back to that example of Christina, and maybe if she had arthritis in her hands or carpal tunnel syndrome or an injury from tennis, that's something we would likely know about that would be interfering with her wanting to go to her tennis lessons. And we see that with golf and with bowling. And if our shoes hurt or our back hurts or we have physical injury, it's easier to see those things and rule them out. And they develop over time or they develop with our knowledge. But this kind of rapid onset of change in behavior or symptoms is more closely correlated to a behavioral or mental health issue. Changes in sleep or eating, decrease in hygiene, decrease in appearance, of course, any evidence of purposeful self-harm, signs of hallucination or delusion, co-occurring substance abuse. And I think one of the biggest indicators to us of a potential mental health need that's unmet or potential mental health symptoms is that these symptoms are occurring across all environments, right? It's not happening in just one specific setting. So we think about, for example, if someone's performance is declining at work, it's an opportunity to check in with them about other symptoms and other environmental factors. If moving to a different location or adding in some extra accommodations reduces the likelihood of the challenge, then that's an indicator to us that it's the environment, right? If we can do things to change the environment and it supports and helps the person, that's very different from having symptoms, having challenges that are persisting across environment. So that's very helpful from a provider perspective. And it also really highlights for us the importance of coordination of supports across settings. And then again, when behavior isn't explained by disability alone, and that's really to address those challenges of diagnostic overshadowing that we do tend to see, where when you have a hammer, everything looks like a nail, and we see problem behavior and maladaptive behavior and challenging behavior, and we tend to qualify behavior as being a negative change when behavior is not only neutral but really useful when we think about how these changes are happening, and to this point here, more importantly, where behavior is changing and where we're seeing those changes. So, our colleagues at the National Association for Dual Diagnosis, NADD, in addition to the work that they do with workforce development, they also created the DMID, which is a Diagnostic Manual on Intellectual Disability. It's a companion manual to the DSM. And essentially what the DMID does is it reconciles this divide we have between signs and symptoms, right? Signs are things we can see. Symptoms are often things that we can't see. So people are oftentimes struggling and challenged by symptoms that they can't articulate or explain. And we're missing that information because there may not be outward signs of it, or the presentation of these mental health challenges are different for people with disability experiences. So our colleagues at NADD have the DMID, which I shared resource with you that we'll look at before we part ways. But I wanted to just really look at the signs and symptoms and really take those behavioral equivalents. Like, I think that we have a good sense of depression, and the typical symptoms that we look at around depression, right? Feelings of hopelessness. It's hard to see that, right? Feelings of hopelessness is a symptom unless someone can articulate that, and then it becomes a sign, right? No longer attending activities that people derive pleasure from, disruptions in work and social life and hobbies. And one of the challenges that we have with depression diagnosis in people with IDD, particularly people who have significant restrictions or significant impairments, is that it's harder to see that change from baseline. Right? If people typically do not have a lot of activities and a lot of friends, and they don't have a lot of opportunities for engagement and inclusion, it's sometimes harder for us to recognize and see that significant change from baseline, particularly in people who can't self-report. So in the DMID2, when we look at the companion manual for diagnosis, we see things like irritability, time spent alone, refusal of previously valued activities, napping frequently, kind of difficult to do things that have a lot of steps or have a lot of tasks, incomplete tasks, decreased work output, right? We may hear and use biased language around these symptoms when we say things like task avoidance or task delay or non-compliance, right? That behavioral overshadowing piece where we tend to label behavior change in that way. But we can see here that this is also what depression looks like, right? Not being able to follow through on steps that have multiple tasks, tasks that have multiple steps, seeking punishment in a way that helps people avoid the things that that they don't want to do or they're not comfortable doing. So we have to think also about what mental health symptoms look like, particularly through the context of IDD, where again, people may not be able to self-report. And more importantly, that presentation might be different. So we talk about treatment approaches with depression because we know that it's so important to have these things available, but there's such an overlap in the benefit of the things that we do, even in the absence of a formal diagnosis. So the things that we suggest and the things that we recommend as best practice treatment approaches for depression are also things that we want to be doing all the time anyway, to really think about supporting people with having good mental health, even in the absence of a formal diagnosis. So regular exercise, stress management, skill opportunities, meaningful activities, right? We want people to feel valued and we want people to feel valuable. And that means relationships with people who are not paid to be in relationships with people. That means having meaningful activities where people feel valued and valuable, and ways to share their gifts in their families, in their neighborhoods, in their communities, and really having social value. And so while we present these as depression treatments, these are absolutely approaches that are going to be supportive throughout the lifespan. When we think about anxiety, again, we want to think about those symptoms that we know that are traditional signs and symptoms of anxiety, but through the lens of intellectual and developmental disability, thinking about, well, what does that look like? And how can we tell that that's happening? And we know that for young people, anxiety tends to manifest as external things, right? There's a monster under the bed, attachment, being disattached from our moms and our family, being out in the world where we can't predict who's going to be there and what's going to look like and when we're getting home. And then as we grow in the lifespan, the older we get, the more we internalize these anxiety feelings that we have. And the internal things become the source of our anxiety. And so while this is different for everyone, we're looking for that change in baseline, and we're looking for a level of fear, worry, anxiety that's just interfering with quality of life. So we talk about this with anxiety, but that's another good guideline we think of mental health diagnosis in general, is that are the symptoms interfering with functioning? Are symptoms interfering with quality of life and really the kind of life that people want to have? So we know that anxiety is different for everyone. There's also physical symptoms that are associated with anxiety, which runs that risk of diagnostic overshadowing, right? Nausea, increased blood pressure, migraine headaches, GI distress, chest pains, those things that can look like anxiety also look like other things. And again, through the lens of IDD, autism, people who may not be able to self-report, we can see that there can be diagnostic challenges there with understanding what's happening. So we know that people's behavior gives us so much information, because people don't always tell us their symptoms, or we don't have all the information. We rely on those changes in behavior. But just because we see the behavior doesn't mean all these other things are taking place. And we know that there are risk factors for people with intellectual and developmental disability that we really want to be aware of, right? Social and communication differences, differences with executive functioning and perspective, understanding nonverbal cues, very rule-based, explicit learning styles that may not lend itself to other places and other settings. Like, I feel very comfortable in my home, in my kitchen, with my family, eating food that I cooked. But now we go to a restaurant and I have to wait there and I don't know who else is going to be there. And it's very uncomfortable and I don't like this food. And there's noises and sounds and smells and textures that I can't control or predict. And we think about all the expectations and what do I wear? And do I ask for seconds? And we don't have cloth napkins in my house. And where's the bathroom? And what if someone's in it? And, there's these additional layers that challenge all of us. And I would also suggest that in a post-COVID world, we are affected by these things perhaps more than before, but we know for people with disability experiences, it's more than discomfort, right? It's really feeling excluded. It's not having the tools to navigate different settings. And what does that look like to us? Well, it looks like agitation. It looks like aggression, efforts to avoid discomfort, intentionally getting in trouble, right? If you clean your room all week, then you can go to this birthday party, or if you finish all your work, we can go out for dinner, but I don't want to go to that birthday party any more than I want to go to dinner. So I know exactly how I'm going to make sure that I don't have to go to these places and be there. And this desperation to access the items or the person or the thing or the place where I know I'm going to feel most comfortable. Again, of course, these experiences are different for everyone. These experiences are different across the lifespan. I think the key piece for us to take from this conversation is to really understand what behavior change is telling us, and to really use those behavior changes as a way to look for and explore potential mental health needs that people have. So we want to have a sort of an collaborative, coordinated approach to helping people get their mental health needs met. And we tend to equate psychiatry and psychology as being sort of the formal treatment approaches for people who have mental health conditions and mental health diagnoses. We also have to think about how we can adapt that for people who have disability experiences. So psychotherapy, individual therapy, group therapy. Group therapy is very helpful for people who have disability experiences. particularly people who don't use language to have expressive language. They may have very good receptive language and can have great benefits from being in a group of other people who have been through similar experiences. There's also the pro-social component of understanding and seeing that other people have these experiences and that we're not alone and that other people can speak to them. And especially for young people to be in those environments. And also, it just takes the pressure off a one-on-one therapy experience that might not necessarily be attractive to some people. So we have a group therapy. We also think about trauma and trauma-informed care, creating safety, connection, and empowerment across settings and across the lifespan. We may need to think about getting more support and helping do that for people. And just really knowing people and what those challenges are and what those triggers are that might make them feel uncomfortable and might make them feel unsafe. We always want to think about health and medicine and access, having a comprehensive support plan that's going to address physical health and emotional support and social and mental health, of course. We tend to focus so much on physical health because we have the metrics around physical health, right? So now we have so much technology available to track our steps. We know how much water did we drink? What is your BMI? What is your cholesterol? How many steps did you take today? Your blood sugar. We have the technology to have the metrics around physical health, which makes things easier and better. And we also, while we're doing that, we want to think about having metrics for other areas of health as well, really looking at wellness as an active opportunity. It's not just the presence or absence of illness, but what are the choices and opportunities that people have to access wellness and nutrition? People who have disability experiences are more likely to experience food insecurity. There was a great study that was done by the Community Food Bank of New Jersey. They found that 1 in 5 people in New Jersey who have a disability also experience food insecurity. Right, that's big. So we think about access to food and fresh food and being able to afford food and just thinking about exercise and movement in very creative ways where we're looking at hobbies and we're looking at opportunities for people to exercise, but also that a lot of the things we do to be healthy and well and eat right are expensive things. And that in addition to disability risk factors, people also experience social and economic vulnerabilities as well. So just again, being very holistic and inclusive when we think not only about the causes of these challenges, but also about the solutions as well. And one thing that's so helpful when we talk about direct support professionals, direct care, caregivers, care partners, teachers, I always talk about the things we don't need a prescription for. There's so many things that we can do to support people in their quality of life, to help them feel valued and valuable, to really think about those moments where people are challenged by their mental health symptoms. And again, to be creative about the things that we can do to support a lifestyle that meets people's needs, right? I think we're really good at having pictures and videos and graphics for people who don't use language. But even for people who do use language, having pictures and video sequences and comic strips and graphics are so helpful because it reduces the cognitive load because I have that additional input of what I should be doing, but also it reduces anxiety. It reduces stress, right? Having a routine, having a schedule, having some visual and picture supports and sequences to do that. I used to work with a young man who had a lot of anxiety about making transitions across settings. He had a job coach and he would go to practice different job sampling. And he would also be at a program to learn some job skills. And the most challenging part of his day was actually moving through these different transitional times, whether that be transportation or changes between tasks. And one of the cool things we did was we had this big picture board for him because this was years ago before we had the computer in our hand all the time. And we had to be a little bit old school with our pictures and our graphics. But and this young guy had made a comic strip and he had drawn pictures of himself, and this little picture of him in a blue sweatshirt, because he always wore a blue hoodie. So he would move himself from the bus to the job, from the job to the school, and from the school to back to the program, and just having little things like this that we know that are going to be helpful for people. All the things that give us value, that help us have a good quality of life, we want to make sure there's access to that for people that we support as well, right? You know, having a job, having employment is a great indicator of quality of life. I mentioned earlier in the National Core Indicator survey data from self-report, these quality of life outcomes, people who have disabilities are less likely to report being employed. They're more likely to report being unemployed or underemployed. People with intellectual and developmental disabilities are more likely to report feeling lonely. They're less likely to report having friends. They're less likely to report seeing their family members. They're more likely to report living in restricted settings, right? We cannot separate out these big macro vulnerabilities from the mental health outcomes that we see, right? People have higher rates of anxiety and stress and disability and depression because this, you know, the neighborhoods, the community is not always accessible for people to get their mental health needs met. So when we think about treatment, we're thinking about, of course, treatment for diagnosis, but also really looking to improve quality of life and wellness for people with disability experiences. I do want to make sure that we have time for questions, but I did very intentionally include some resources and tools that I think are going to be helpful, especially from a provider perspective as we move to include, to kind of elevate our capacity in these areas. First of all, the link to the Boggs Center, which I'll tell you more about. MHDD is the Mental Health and Developmental Disability Training Center, and they have created some lessons that are accessible to people with disabilities and their families, their care partners and providers. Many of them are in English and Spanish. Some of them are in multiple languages as well, and they are interactive. They have resource lists and scenarios, and they're Disability 101, Autism 101, Depression 101, Anxiety 101. We did work with them to build some of those lessons. They are free, they're accessible. There's a link to them there. I want to also highlight the work of NADD, the National Association for Dual Diagnosis, which is one of our partners in New Jersey and nationally, meeting the mental health needs of people who have disability experiences. And as I mentioned before, one of the publications from NADD is the DMID, which is the Diagnostic Manual for Intellectual Disability. These are the behavioral equivalents for the diagnostic criteria that is presented in the DSM-5. So if you wanted to see that more inclusively, our colleagues at NAD offer that for free, the first chapter, so you can click on that link to see it. And as Catherine said, we'll make these slides available to you. I also wanted to highlight a tool from our university partners at Vanderbilt. And they've been working for quite some time on tools such as the one that you see, which really gives providers and care partners the real-time tools that they need to just understand people's needs. So this is a tool in the what they call the IDD toolkit. This particular tool in the IDD toolkit is intended to identify symptoms of mental health needs and signs of mental health distress in adults who have IDD experiences. So in addition to the screening components that they share, it also helps give guidance on how to differentiate between different disorders, you know, with the risk of diagnostic overshadowing, again, being high for people who have IDD experiences. It also, you know, breaks things down into different signs. And I think one of the best pieces of work that the IDD toolkit provides is that there are these fillable forms. There's ways to practice signs and symptoms. And that piece of coordinating with health professionals to make sure that health professionals have the information that they need and to understand, I think is very helpful. And so I just wanted to show you this tool briefly. You will have access to it, but we're so grateful for the continuing work of our colleagues at the Vanderbilt Kennedy Center for the IDD toolkit. And another piece of the IDD toolkit is this piece on working with providers. In addition to my role at the Bog Center, which I'll tell you more about in a minute, also a doctoral candidate at the School of Public Health, and I'm focusing on building capacity of mental health providers to meet the needs of people who have intellectual and developmental disabilities, really exploring those barriers to training. We know that people who are studying psychology and are studying to become psychiatrists and psychologists and counselors don't necessarily have a training or a rotation or a formal component of the curriculum to look at accessible services for people who have disability experiences. So while I'm not there yet, our friends at Vanderbilt are. So I wanted to also share this with you as well. Tips for mental health providers. People ask us all the time, where do I find a therapist who works with people with IDD? Where do I find a psychiatrist, a psychologist who understands my son, who understands my sister, who understands my kid? And you are the one who has the expertise, right? It's up to us to build this expertise throughout the provider community and to share these resources. So share them, right? We need to educate prescribers, we need to educate providers about the needs of the people that we support, and having tools like this makes it a lot easier to do. Our colleagues at the National Alliance for Mental Illness have this great tool in taking charge of your mental health. This is great across the lifespan, but particularly for younger people and teenagers who may be transitioning into a larger role of empowerment to manage their own symptoms and to manage their own mental health needs and even their physical health needs. So I really like this tool because it's a helpful infographic that we can use. I love this. If I have questions, if I have thoughts that scare me, what should I do? How do I, how long will it feel for me to take better, to feel better on this medication? These are great questions and great opportunities for having these kinds of conversations just in plain language. As important as it is for us to have the evidence-based knowledge to implement best practice, it's also so important that we have these accessible pieces for people to be able to have accessibility for themselves. And then I also wanted to share this tool from SAMHSA. It's pretty hefty. It's very helpful. You can find the pieces that you think are going to be useful for you and the people that you work with and support. This is a step-by-step guide to wellness. And really it's focusing on the things that people can do, we can do with people, things that we can do for each other on these 8 dimensions of wellness. As I said, we're very, we spoke earlier with our colleagues around, the medical model. And the reality is that in disability services and human services and in healthcare, we tend to look at things through that medical model with the focus on physical health. So it's up to us to also be more intentional and planful about ways that we can create opportunities to just elevate these other areas of health. So I wanted to highlight this tool as well. And it includes things like sexual health and education and medication safety and tobacco and alcohol and drug use, and worksheets and workbooks for people to start to make this plan. And also, we aren't explicitly talking about it here in this course, but also thinking about emergency preparedness and making sure people have access to the things that other people in the community will also have access to in the event of an emergency. So that's helpful to have as well. So those are the tools that I wanted to include for you. And these are some, of course, New Jersey specific tools and hotlines and resources that I think are always helpful for us to have. Even if we have them somewhere else, we have them in front of us. The Bog Center on Disability and Human Development. We are the New Jersey's University Center on Excellence in Developmental Disability. We work in great partnership with support from the Division of Developmental Disabilities. And we do a lot of community trainings and education for community providers and family members and DSPs and individuals receiving services throughout the state of New Jersey, particularly through DDD, the Division of Developmental Disabilities. So most people find us through their trainings, needs, and or through opportunities like this where we have to present and we have opportunities to share the work that we do in these types of educational events. But I do invite you to visit the Bog Center website to see the other resources that we have available. We have a developmental disability lecture series that is made available through DDD, and those lectures are free to individuals and providers and family members. We invite you to look at the schedule and join if you can. You can also find resources for previous lectures on our website. We have a lot of publications in helping people navigate services, finding a support coordinator, finding a behavioral service. Many of these things are in English and Spanish as well. Resources on grief and loss. We have a video library of previous recordings of trainings, information on our conferences. And all this that I've just told you about training and education is just one piece of what the Bog Center does. They also, we also have training and, pre-service training for professionals through our LEND program, our leadership and neurodevelopmental education program. We are preparing and elevating the next generation of health professionals. So we teach the medical students and the School of Social Work and our public health colleagues just to make disability part of the curriculum there. And of course, a lot of research and training and other resources that you'll find on our website. So I wanted to make sure that you have it so you know where to find us, and also to get support with other things that you might need in the community. And of course, classes on mental health and dual diagnosis, and opportunities for you to check out other things that are going on in the state to help you to do your job better. So I know we wanted to have time for questions, and I wanted to make sure that we did, but I also wanted to, rather than just drop a resource list on you, I wanted to make sure that you could see specifically what they are and how to use them. So thank you so much.
Well, Melissa, thank you. Thank you so much. And you've already received some thanks in the chat for all the resources. So, so people really appreciate the resources. They think they're great. They think they're cohesive and it's a well-presented topic, and they're very appreciative.
Great.
Does anybody have questions? We can open it up. You can either put it in the chat or you can unmute yourself and ask Melissa directly.
Hi, Melissa.
Hi, Melissa.
Hi, how are you?
I'm great. Thank you for joining.
Well, thank you. Could not miss it when I saw all the topics and the presenters. You had a slide up that had some maroon and gold in the slide. No, wait, I think it was the resources slides.
Oh, okay. So let me see. Let me see if it was related. Was it related to the IDD toolkit, perhaps?
I believe so. It had a whole list of them, and I tried to get a pick and I couldn't.
Oh, sure. Yeah, and we'll share these. We'll share these with you,
Okay.
so that you have the chance to look at them. But for this particular slide, maybe it related to the IDD toolkit or the wellness, do we think?
Hold on. I appreciate that.
Yeah.
Hello.
I'm not sure if this was exactly the slide that you were looking for.
Okay.
But this was the part of the IDD toolkit that speaks to working with providers.
Yes.
Had a feeling. So also on this IDD toolkit resource, and I appreciate that you gave me an opportunity to elevate this once again. In addition to the actual document itself, there are links embedded into this resource that take you to other tools. So see, help with emotional and behavior concerns, risk assessment for behavioral crisis, psychotropic medication review, which I love, because there's always conversations and debates around psychotropic medication for people with IDD. People take too much medication. People take not enough medication. People take the wrong
Right.
medication. And of course, the bottom line always is that's a person-centered, data-driven decision that needs to take place between the individual and the prescriber. So having tools like this with a medication review, develop that data that we need to work with prescribers.
Thank you so much. I really
course.
appreciate bringing that back up.
Absolutely.
Hello.
Hi, Sandra.
Hi.
Hi.
I had to step away, and I'm not sure this is a topic that you discussed, but what if somebody they have the mental health diagnosis, but there's a suspected IDD based off of conversations with them stating that they had IEPs? How do we go about getting them services? I know that there's a website online, like going through the DDD, but is there an agency or organization that can help somebody go through that to get them that proper diagnosis so we can get them the help that they need, the dual diagnosis help, and also it helps us as a provider to address their needs. Not, I don't want to use the word differently, but approach it at a different, like knowing that that person officially has this diagnosis, we can approach differently or provide different services based off of the official diagnosis.
Yeah. Sandra, I think you bring up a very important and common point. For those of us who are providers of services, we are often aware of that disability diagnosis first,
Mhm.
and we're trying to go find mental health supports for people with a known disability diagnosis. And I think that, you know, it's hard to say that people have a mental health diagnosis and you're looking to identify that IDD diagnosis. So I think you answered your own question, which is that we want to work with our colleagues at the Division of Developmental Disabilities. Children who are under 21, we want to work through Perform Care with the Children's System of Care to seek out those services and those evaluations. So it depends where children are, adults are across the lifespan. So DDD is our connection for adults over 21. The Children's System of Care through Perform Care is our connection through. And for young children under 3, Children's Specialized Hospital, Children's Specialized Services has screening tools for that. So Sandra, I don't know if I'm answering your question. This might be one of those reach out to me separately and maybe I can help you. But in general, for diagnostic assessments, we do look to our state partners to be able to provide those resources.
But I have a few individuals that we work with, they have the mental health component, but they're suspected DDD. However, they're adults, potentially in their late 20s and early
Yeah.
30s, but based off of information and talking to other agencies or organizations that are working with them, there's been this suspected IDDD diagnosis prior to 21 or prior to 22. Just we also don't have the documentation, like
We
trying
have
to
the
get that
documentation
document.
for it. Yeah. I would say to look at to connect with our DDD colleagues around that. I would
Okay.
also say that, you know, sometimes we don't, just because we don't have the documentation doesn't mean that there isn't any. So if you are supporting someone who is over 21, but you have knowledge or access to their school or their school program, maybe
Yeah.
being able to talk with their services that they got in school, or if there was anyone that was supporting them in school that might be able to provide that information too.
Yeah, my program doesn't work with the schools. I mean, not that we
Yeah,
can't,
because they're older.
it's not that we
Yeah.
can't help them. It's just that's not something that we regularly that we
Mhm.
do on a regular actually that we
Yeah.
have ever done in this program is
Yeah.
reaching out to only one time. So
We do tend to have that kind of arbitrary line in the sand with lifespan issues when kiddos turn 21. That is a challenge that we do have, particularly if we're not working through transition in a formal way. Sandra and others, I did drop the link for the Division of Developmental Disabilities into the chat to really talk through how to receive services and apply for services. And if, as you said, you're missing documentation or kind of formal diagnostics around that, they should be able to help you with that too.
okay, thank you. I'm gonna.
Does anybody else have a question?
Hi, it's Kimberly Donahue. Melissa, I'm not going to take up anybody's time, but I did want to thank you for putting this on and arranging this with Catherine. As a member of the Board of Trustees of Nutley Family Service Bureau, we appreciate it. And I do see on the list that a few of our trustees are here. I'm also an attorney in Nutley, and I happen to also be the parent of an adult with disabilities. I have a 24-year-old with autism, and we're always talking about these same things. And it's just so good to hear everybody collaborating. And I just wanted to say thank you.
Wonderful. It's my honor. I've worked with the folks at Nutley Family Services before and doing some smaller training. So I'm grateful to have this opportunity to speak to a larger group. And Kimberly, you highlight something so important, that people with lived experience and people with family members, like, we also have jobs in the community where we're in a position to help other people do these things. So I think remembering that people wear many hats, finding the overlap there, I think it's just only going to build capacity. So thank you for that.
Anybody else? We have a couple more minutes. I don't want to leave anyone out.
I'm also easy to find, Catherine. So folks are welcome to reach out to me if they think of something later. I'll be happy to coordinate with them.
Thank you, Melissa. I mean, thank you so much. And that we will be sharing the slides. We will be sharing the recording. Melissa has her information for everybody. Melissa, definitely the first time I had this training opened my eyes to a whole nother way of diagnosing, right? I didn't even know that that there was another diagnostic manual that was a companion now to the DSM, right? So it's just led me on a search for more information, and I really appreciate everybody's questions. I want to thank Sandra for bringing up her question, because that's something that we have been seeing, and an issue that has come up at NFSB, right? Like people who are now adults who were not diagnosed and need services. So that's a whole nother area that I'd like to explore and talk more about with people in the field. And I know it's a topic in the mental health world about, how you collaborate more with the people on the disability side and
Absolutely.
work on bringing
Yeah.
these services together.
Absolutely.
Yeah. So Melissa, do you have anything else to say? I mean, I really, really appreciate you being here.
No, it's really my privilege and honor to speak to everyone. I really appreciate everyone's interest in this topic. I know that there are a lot of different initiatives throughout the state to make sure that we are working together and coordinating. The Governor's Council is having a symposium as well on disability and mental health that is open to everyone. So I will share that with you, Catherine, so you can also elevate that as well. And I think as my colleague Monica Wiley said before me, if we keep having these conversations, it really continues to highlight the imperative to move forward. So thank you for allowing me to be a part of it.
Thank you so much. And I hope that you can, if you have time to stay on with us. I know you were here for most of the day.
I certainly will. I'll be here.
Great. So thank you again. I hope to have you back and definitely share the resources on anything that we would be interested in, and we'll promote it.
Wonderful. My pleasure. Thanks to everyone. Have a great day and enjoy the rest of the symposium.